Welcome to this concise video log titled Using HIV-ASSIST to Guide ART Selection in a Treatment-Experienced Patient with Comorbidities. This video log was recorded by Dr. Ethel Weld, and this activity is provided by Clinical Care Options and supported by independent educational grants from Gilead Sciences, Theratechnologies, and ViiV Healthcare. This vlog was recorded by our expert faculty, Dr. Ethel Weld, Assistant Professor at the Johns Hopkins University School of Medicine and attending physician at the Johns Hopkins Hospital in Baltimore, Maryland. This vlog is part of a comprehensive educational program on using HIV-ASSIST as an educational resource for selecting ART in patients with HIV. You can obtain downloadable slides on the Clinical Care Options website, as well as gain CME, CE, or CPE credit by viewing this vlog.
Hi, I'm Ethel Weld. Thank you for joining today. I just saw a patient in clinic that I wanted to discuss, and particularly wanted to discuss how I think we can use the tool of HIV-ASSIST to learn some things about this patient and to integrate into best practices for his care. So starting out with the patient case, we're seeing a 68-year-old man with HIV diagnosed in 1999. He comes into clinic. He's been on multiple regimens over the years with sometimes intermittent adherence. Not totally sure which regimens he's taken over the years. He's currently taking dolutegravir plus the combination of TAF and FTC. But he's worried about a little bit about some of his comorbidities, and he wants to get back on track with his medications. He has multiple comorbidities. He has CAD, so coronary artery disease, status post an MI 2 years ago with percutaneous coronary intervention. He has hypertension, hyperlipidemia, and diabetes. His A1C is 7.2. His LDL is 160. He is mildly obese with a BMI of 35. And looking at his other parameters on the right, you can see his CD4 count is 187. It has now dropped below 200. His viral load is not suppressed. It's 31,000. And he has the listed mutations that are seen on genotype. He is known to be HLA-B5701 positive, and the medications that he's taken are listed below. So what you would do to put this input into HIV-ASSIST is you would click under the adherence tab that he has had intermittent adherence. You'd put in his CD4 count and viral load, the fact that he's HLA-B5701 positive, which will mean that no abacavir containing regimens are suggested because that confers a risk of fatal abacavir hypersensitivity. And then you enter in all of his comorbidities, all of his co-medications, and the current regimen he's taking. Then you see the output for those options that you selected. And you can see that the highest prioritized regimen, the one with the lowest score, which means the most preferred regimen, is COBI-boosted darunavir with TDF and FTC. So if you want to dig a little bit further into why this is prioritized, you can click on the additional information tab, and you can see information about his comorbidities and considerations surrounding his ART. So what we see when we're just looking at hyperlipidemia, so just his hyperlipidemia into consideration, we can see that the impact of abacavir is that it can increase triglyceride and LDL levels. Not relevant for him because he's not on abacavir and cannot be. TDF has been associated with lower lipid levels than abacavir or TAF, and the DHHS guidelines actually state that that lipids do appear to be more favorable on TDF than on TAF. And then in terms of all of the darunavir-based regimens, all of them can cause an increase in triglycerides and LDL levels. In terms of the clinical impact of this dyslipidemia, that is a different question. So these are the guidelines. This is just, the scenario of high cardiac risk. He has high cardiac risk because he's already infarcted one of his coronaries. So the consideration here is just thinking through whether you want to avoid PIs, avoid abacavir, and just keeping in mind the regimens that are associated with more favorable lipid profiles. And then below, under hyperlipidemia, it tells you that PI-based regimens, efavirenz, elvitegravir have been associated with dyslipidemia, and that TDF has less of that than abacavir or TAF. So this is a study demonstrating that that looked at the effect on lipids of switching from TDF to TAF and then back again. So what were the differences in total cholesterol in switching? And it was a retrospective study of suppressed people with HIV. And there were about 385 patients. There was a mean increase in total cholesterol at 24 weeks on the TAF regimen that was significant, of about something like 18 milligrams per deciliter. And then in the patients that were switched back to TDF, there was a decrease in total cholesterol from 202 to 185, plus or minus. And again, that was highly significant. You can see these changes displayed at the right. So the HIV-ASSIST output does have additional information on coronary artery disease and ART and that interplay. And so what you would do is you would click on the additional information tab, and that would take it divided by comorbidities, what the considerations are around the various ARTs. So you can see that abacavir is listed as having been associated with an increased risk of MI in some observational studies, and that the risk was greatest in patients with traditional cardiovascular disease, so that there was some concern about needing to avoid abacavir-based regimens. And you can see that further down for darunavir, slightly penalized because it could potentially be associated with an increased cardiovascular risk. So just wanted to bring up some recent data. This is the DAD study, so the data collection on adverse events of anti-HIV drugs. And it actually showed, adjusted for every imaginable covariate you can think of that impacts cardiovascular risk, it showed an increased risk with darunavir-based regimens, with ritonavir-boosted darunavir, by 50% increase per 5 years of darunavir exposure. It's worth noting that atazanavir does not have this association. Atazanavir does not have any increased risk of MI or cardiovascular disease, and that's hypothesized to be due to the beneficial kind of antioxidant and anti-inflammatory effects of unconjugated hyperbilirubinemia, which is a known, well-characterized side effect of that drug, but that may be cardioprotective. Moving on to another analysis, which looked at all of the randomized controlled trials involving darunavir, ritonavir that Janssen had in its databases, and looked at whether there was an increased risk. This is tricky because people living with HIV have an increased risk of cardiovascular disease anyway, but they examined clinical characteristics and looked at the incidence rate of cardiovascular disease per 1,000 person years, which is plotted here, which is around 6 to 8, and then does seem to decrease over time, which goes against kind of a cumulative burden impact on cardiovascular disease. But this was non-comparative. They weren't comparing this to non-darunavir containing regimens. It's just making the observation that there may not be a increase in cardiovascular events that is of concern with ritonavir-boosted darunavir. And then if you go back and if you had changed your HIV-ASSIST input to include at least 3 active drugs, this is an elderly guy, lots of comorbidities, doesn't have a lot of room to move here, has virologic and immunologic failure with a CD4 count now below 200, current regimen not working for him, really would love to include 3 drugs. If you click that button, your output is slightly different, and regimens including a drug called ibalizumab do display. And you can see that, for example, the regimen 3 options down, which is ibalizumab plus COVID-boosted darunavir and TDF-FTC, is ranked fairly favorably compared to other options. But this is into the territory of salvage regimens. There's always the option to consider seeking additional consultation and click the Start Discussion button. which appears in the reports tab. And once you do that, it actually brings up the opportunity to link your case narrative and information about your case to the National Clinical Consultation Center at UCSF. And you can also send your case to HIV-ASSIST for review by the Scientific Advisory Board, depending on the availability and the case burden. But both of these resources are free and are a good idea if you're facing a treatment-experienced gentleman with multi-class resistance and treatment failure. But if you're interested specifically in co-medications, there's a possibility of interaction. And when you're looking into that, you click on the dosing info tab on the education sheet. So the education sheet has these 3 tabs, and dosing interviews what you click. And it takes you to a consideration of co-medications, and it's displayed by medication. So if you're just looking under atorvastatin, you see that darunavir plus atorvastatin, boosted or not, basically is going to boost the atorvastatin levels. So you should not exceed 20 milligrams of atorvastatin daily. That's really similar to 80 milligrams of atorvastatin on someone not taking these boosters. And if you go further, if you're concerned about metformin and dolutegravir, for example, if you're considering twice daily dolutegravir, you can look that both dolutegravir and bictegravir do increase the AUC of metformin, dolutegravir more significantly. So there is a drug-drug interaction, but they can still be used just with close monitoring and potentially with different starting doses for the metformin. But the take-home points really are that this can be a helpful resource to guide ART selection in patients with multiple comorbidities and co-medications, lots going on, treatment failure, advanced resistance. And that if you are dealing with a case like this involving multi-drug resistance, seeking additional consultation is not just available, it's wise to do, and it's possible to do with an HIV-ASSIST. Just making the points that TDF is more favorable for lipids than TAF, and that's built into the algorithm. Not super clear what the clinical endpoints are associated with that. And then abacavir and to some extent boosted darunavir, potentially based on observational data, may be a concern in people with HIV with a history of MI, but sometimes you do not have other choices. And the maximum dose of atorvastatin in people on boosted darunavir is 20 milligrams daily. So the first thing you would do to his 80 milligrams of atorvastatin would be to decrease it if you were switching into this regimen. And that a dolutegravir-based regimen is a bit penalized with metformin, but still doable with a dose adjustment. And that potentially incorporating regimens like ibalizumab could get you to preserving a once-a-day regimen of, for example, COVID boosted darunavir plus TDF-FTC, and just a every 2 weeks injection. So for some patients who have had experience with taking handfuls of pills multiple times a day, it's relatively doable. So that's all that I wanted to get to here today. Thank you so much for listening and thinking through this case with me and considering how to use HIV-ASSIST. Good luck to you.